Chinese scalp acupuncture takes advantage of the anatomy of the cerebral cortex that we all know and love. Today's work, we're dealing primarily with the motor and sensory cortices because those are the two territories that are indispensable to address with most pain problems, be they chronic or acute. Clearly, in the full breadth of scalp acupuncture's application, we take advantage of the parietal lobe, the occipital lobe, the temporal lobe, even the frontal lobe for some of the visceral work that we do. But today, on our first exploration of the Chinese scalp acupuncture, I want to concentrate on getting you comfortable with the motor and sensory cortices. The first and most important thing to do is prepare the scalp by a firm, deep massage, stretching out the sclerosed and fibrosed connective tissue fibrils that somehow, I have no idea how or why, that somehow tend to get tight and hard in the territories of people who have chronic pain problems. So it's important to get a mobile surface in that loose connective tissue between the aponeurosis and the pericranium. If you don't loosen it up well at the very beginning, you run the risk of causing more discomfort as you're poking your needle through stiff connective tissue. So prepare the scalp, and the goal of your needling is to slide a needle in that loose connective tissue between the aponeurosis and the pericranium. From this image, it looks like a daunting and difficult task, but in clinical reality, when you've got your needle positioned well and you've got your needle under your control, it's not such a difficult challenge. It's actually quite straightforward. You need to be prepared to back out and go deeper if you're stuck in a rubbery type substance that is the aponeurosis that both feels not right. It doesn't give you the smooth flowing that you want in the connective tissue. Also, that's when your patient will say, you know, doc, that's uncomfortable. That hurts. Please, can you stop or back out and do something different? So the other obstacle that you encounter when you're advancing the needle, and the goal is to take the needle as far as it will go, ideally to the hub. When you're advancing the needle, if you hit against a bony obstacle that's not rubbery, it gives you no resistance other than bone, you're poking against a lump in the pericranium. You can try to back out, aim up a little bit to try to go over it, but I would say that in fewer than 25% of the cases where you bump against the bone, will you be able to back out and advance it. What you do then is simply take another needle, put it just past the tip of where the first needle is stopped, and insert again and continue your threading. So the steps are preparing the scalp and then measuring for the markers, the anatomical markers, so that you know more or less, as best as one can know, working from the outside with manual techniques, best identify the important landmarks so that you can put your needles over the sensory and motor cortices as precisely as possible. And I've asked Mitch to demonstrate that on my head so that you can get a sense of how that works.
There's three basic approaches to finding the go point, the home starting point of your marking of the scalp. The first technique is to find the midpoint of the scalp, which is midpoint between the glabella and the occipital protuberance, the inion. You can use your fingers as calipers and subdivide that space, try and find the mid position and put in your needle. Or you can use a Kuhn stick, which is conveniently marked with large incremental markers every 5 units. And if you take a space which has 5 big marks or 4 spaces, it will allow you to gently stretch from the inion to the glabella. You do the stretch before you lay it on. And then where that middle point is becomes your midpoint. So now let's do it. Oh, the third technique is where you actually close your eyes and you spin around and you just kind of go like that. But that's not the preferred method. So let's do the...
TOs do?
No, that's what pin the donkeys do.
Or is that a specialty for the neurologist?
The neurologists need all that extra help. Yes, they do. So the technique is to take the needle that you're going to use, the marker needle, and to put it facing outwards between your second and third finger so it's available for you to use, but you can touch the person without worrying about poking them at the same time. So I've got 1, 2, 3, 4, 5 big marks, which is 4 squares. I'm going to stretch it out so there's play in the unit. I go from the glabella to the inion. If I'm having trouble technically, I might ask the patient to help me, but if they don't have arms or stuff like that, I wouldn't. I'm going to put this one in off the midline, and then I'm going to compare it to where the point would be if I did it with a caliper technique. And then I'll show you the next phase. So the caliper technique says, these are your calipers. So part of that has to do with the size of the head of the patient you're working on and the size of your hands. If you've got really teeny hands, if you've got a giant cranium, not going to work. If you've got generous hands and they've got a little head, no problem. So this is where the midpoint comes to when I do the calipers. You can see, I can't coordinate that, but you can see that. They come to the same position. Now the next thing you're supposed to do after you put them in properly is to make sure that you're in the midline. And that has to be done from the front. So you sight up the nose, forehead, and go, by golly, those are off to the left. So you move them over. Not both of them, because you only need one. Take the other one out, because you don't need it. Go back and look, see if you've moved it enough. Probably a little bit more. So what you've seen is a relative similarity to doing the Kuhn stick and doing the caliper measurement technique for finding the midpoint. And when you think about the techniques we're going to be using, which are techniques applied to regions like the motor strip, the sensory strip, the motor strip, the sensory strip. So it's not like a point or a millimeter off one way or another is going to screw up your treatment because it's a regional treatment that you're giving. So this is, in a certain way, forgiving in that regard. This is how you find the midpoint. Want me to leave it in or take it out? Any questions about how to do that?
Take it out, and Doug's going to start anew. These, we use the U30s for the markers because, number one, you hardly feel them going in, and number two, they're a different color. We're putting in marker needles to anchor our measurements to locate the midpoint, the top and the bottom of the sensory and motor cortices, the lines that you're going to be using in treatment. You will always be marking the midpoint and almost always be marking the sensory and motor top cortex. But as you get used to doing this, as you've done your first 25 or 50, you'll no longer have to mark the lower point, but to be able to see that and be able to visualize. One perversity about working on human beings, they have big frontal lobes. So because of that, you can't just divide the head and say, well, halfway, but
So, to continue the lecture here, there are two things you need to know about scalp acupuncture.
okay, you are.
Yeah, two things you need to know about scalp acupuncture. One is how to put the needle in. We just did that. The second is what area are you going to work with the scalp acupuncture. Let me just, again, use a needle to mark the midpoint, and I can stand here to do that, I think. Using your hands, if your fingers are spread out the same distance, then your thumbs must be in the midpoint. And let's see, that's the midpoint. And again, we'd like to check that. That point is exactly in the midline, and I was off a bit, so I'm going to move that a bit. And you do that by walking around, looking at the face, following the nose up. I'm going to check that that is in a good position with my Kuhn stick. And again, I'm going to use 4 areas, go from the inion to the glabella, and that is exactly right. Okay, that's the midpoint. Now, we know that our Kuhn stick is 2 centimeters. This is very convenient because then we'll put a marker in the midline again, 2 centimeters behind the midpoint, and that point is the point of the sensory cortex, 2 centimeters behind the midpoint. We'll put another needle in 1/2 centimeter behind the midpoint. And these points should all be, I'm fussing a little bit just to get them to line up good so you can see them good, all be in the midline. I think you can see that well. All right, so these are the tops of the motor and sensory cortex. You want to delimit where the cortexes extend anteriorly and laterally. And the way you do that is you take the high point of the eyebrow and the occipital protuberance. Use a Kuhn stick. And where your Kuhn stick crosses the sideburn is the motor cortex lowest point. So again, have your needles ready, and you can easily hold them like this as you do so. And as you measure, right here is the lowermost point of the motor cortex. And 1.5 centimeters behind that, approximately here, is the lowermost point of the sensory cortex. So the motor cortex and the sensory cortex run in this fashion anterolaterally. So you're going toward the cheek. If your needles are not going toward the cheek, you're off somewhere. Rethink what you're thinking. So the other thing we need to think of is we need to divide this. My Kuhn stick's getting a little old and ratty. I'm going to use a new one. We need to divide these strips into fifths. And to do that, I'm going to use a Kuhn stick. And I'm going to go every second marking is a fifth. So the upper 1/5 would be here. Can you turn your head a little bit, Joe? Like this? Thank you. So the upper 1/5 would be in this area here. The middle.
If you want, you can move it. There's a black pen on the podium.
Dry erase marker? Okay.
You want me to hold something?
No, I got it. So here is the border of the sensory cortex. Here is the border of the motor cortex. And excuse my almost straight lines. So the upper 1/5 of the areas would be here. The middle 2/5 would be here. And the lower 2/5 would be here. Now, why are we talking about this? Well, we go back to the homunculus. The neck, spine, and lower extremity are in the upper 1/5. The upper extremity are in the middle 2/5. And the face and head, lower 2/5. Questions about that? Is that pretty clear? Everybody saw that? So this is what we'll be doing after lunch. And this is your thought process. So where is it your patient has some issue? How does that correspond to the motor or sensory cortex or both? And also, it's a contralateral kind of a thing. So if you have a left knee issue, you have to needle on the right cortex, okay, or surface of the scalp. Questions? The back fits in the upper 1/5. So the upper 1/5 incorporates the neck, back, and lower extremities.
So if you have pain on the back on sort of your lower back a little bit more on the left, do you only treat the right cortex, or how do you work with that?
There's also about a 20% crossover in neural function, either sensory or motor. So you would do bilaterally. You'd work bilaterally. We'll go through a whole protocol of what a low back treatment would be and how to do that after the break.
As you get to the technique, the last step that you do is foot motor sensory, and it cuts across where the sensory and motor cortices needles are. And I worried about it at the beginning, thinking, is there going to be a log jam? Am I going to bump into them? Am I going to twist the needles? What was going to happen? I've never had any sense that one is obstructing the other, even though officially we're going in the same level of connective tissue. So that's not really an issue. So what we wanted to do before break is to show you the measurement process. This is the one I use all the time. You use the Kuhn stick if you're awkward or need some confirmation at the beginning of your time. The value of the Kuhn stick is that you get a nice clear 2 centimeter distance between the central marker and the top of the motor cortex. It's also a nice way to visualize the top of the eyebrow to the occipital protuberance, which are territories that you're going to be doing all the time. I always put in a central marker up top. I recommend that for the first 20 to 30 treatments, you put in all these markers so that you start to see them clearly. Because you need to, once you start threading the needle, running down the cortex, you need to make sure that you're seeing the entire line going from top to bottom. And that's the value of having the markers in place, is being able to see a marker needle on top and a marker needle on the bottom as you're then threading it. So what we're going to do after break, or after lunch, is each of you will mark your neighbor with all of these points, and you'll be walking around for an hour or two with all of these marker points in place. Then we're going to go through an exercise of the problem that you're going to treat most commonly, which is low back pain. No, actually wrong. We're going to do a problem that you see commonly but not most commonly, and we'll make it a lower extremity problem so that you get used to working on only one side. With lower back pain, upper back pain, neck pain, you're doing everything bilaterally. So for our first exercise, we'll do something unilaterally so you get a sense of the sequence of needling until you get the result that you want. Okay? That'll be the beginning of the afternoon. But rather than send you out to lunch with these needles sticking in your head, knowing that you'll have to come back with them still in place or have them replaced, we'll break for lunch first, come back, put them in, and then take you through a unilateral lower extremity problem from which we can build all of the other musculoskeletal pain problems. Most of what you're going to be doing with scalp acupuncture until or unless you're in a pain or a rehab center where you're dealing with multiple sclerosis and Parkinsonism and post-stroke and spinal cord injury patients, and the difficult rehab process is going to be dealing with the motor and sensory cortices rather than the other functional or visual or hearing and vertigo type cortices. We'll go through those again. You've seen them on the video. We'll go through them again so that you understand how it all fits, but we'll concentrate on the most common problem. Following the party line, you prep the scalp. Everyone remember to do that? Believe it or not, that's one of the toughest things to remember, to break into your routine. It somehow is tough to hold on to. You then find the midpoint using, how were you with the two hands? Did that land up being pretty comfortable? Those of you with more hair will provoke certain awkwardness the first time through. You just have to push down to the scalp and make sure that you're in the right territory if you're dealing with people with big hair. Measure for the midpoint, or if you're not comfortable with doing it that way, use the Kuhn stick. Stretch that out. You like your Kuhn sticks?
Love it. It's marvelous.
This is an HMI. This is an HMI invention. This is not come from the Chinese tradition. We had to get. It's true. Well, we know that when that's out, we will have trained 20,000 doctors, which is a landmark. Well, maybe 19,000 for those that are lost them. We put the midline marker, confirm that it is indeed midline, and then flip back to the 2 centimeters behind the midline marker that identifies the top of the sensory line. Then divide that into 3 so that it becomes the top of the motor line, top of sensory line, top of motor and sensory line. Then see the intersection between the top of the eyebrow and the inion. Note where that intersects the anterior hairline. Put that as the marker for the bottom of the motor area, and then 1.5 centimeters behind that, not 2. It's not a Kuhn stick width. It's 1.5, which is the distance from the motor to the sensory. Mark that with your marker needle as the bottom of the sensory line, and you've got all things. You've got all of those landmarks in place. Then, using the Kuhn stick, visualize five divisions going, and that reminds you of how this is related to the homunculus, where the bulk of the problems that you're going to be treating are dealt with within the upper 1/5 of sensory and motor. I mean, that's where the bulk of those locations are. When you get to shoulder, elbow, wrist, and hand, that makes up pretty much the entirety of the middle 2/5. And then head issues. This is trigeminal neuralgia. This is intractable headache. This is auricular and nasal area for sensory and motor. That goes there. You'll be doing far less here than you will here, and less here than you will there, which is why we're concentrating today on the upper 1/5. Now, there was in the early development of scalp acupuncture, which is a new phenomenon. It's a new Chinese phenomenon that brought to the States by someone who trained at the center where CSA was developed in Harbin. It's new. It's not been part of the tradition. An argument came out amongst the early developers as to whether you use the head and neck area for cervical pain, or whether you use the upper 1/5. And certainly in our experience and our training and our reinforcement, anything that goes up to the occiput, from the foot to the occiput, is accessible through the upper 1/5. If you don't get what you want with the cervical and the occipital region with the upper 1/5, then you may go down to the lower 2/5. The lower 2/5 have the disadvantage of overlying the temporalis muscle, which, as you've noticed, just with putting these anchor points in, is more uncomfortable putting in a simple needle because it's got there's muscle as opposed to going straight into aponeurosis, and its innervation is finer than up top. So it's a little bit uncomfortable to needle down here, especially as you're trying to stay surface. You're not going into the muscle. You want to try to stay surface, just superficial to that first level of fascia. So that's one of the reasons that we stayed away from working it for cervical problems. But in fact, most of us have agreed that anything up to the occiput is accessible up here. Use this only as a distant second choice. Does that work? Fine. The process then, what we want to take you through next, what we want to take you through next is understanding the approximation of the fifths. And when you've done this for 25 times or 50 times, depending upon how long it takes you to get used to it, after a while you really only need to mark the midpoint, because you'll be able to see 2 centimeters and 1/2 centimeter. You'll be able to trace the line down to the intersection with the anterior hairline and then go back 1.5 centimeters. Until you have that comfort, however, take the time to mark these fifths. You're dealing with an unlimited experimental population with your patients. You can spend as much time with them as you need to until you're comfortable with it. Get comfortable likewise with the division of the fifths. Here again are the layers of the scalp, and we're trying to get the needle between the aponeurosis and the pericranium. This is cranium. This is pericranium. This is loose connective tissue, and that's the skin and aponeurosis here. You've put in one needle into a scalp, so you've you've threaded one needle into the scalp, so you've broken that concern barrier. You've also generously needled your clementine. Work on those again, work on the clementines again if you're still feeling a bit awkward about needling your neighbor. When we teach non-military physicians, we allow them to consider using a guide tube. I don't like guide tubes because I don't have a sense of where I am, how I've started, what level I'm at, so I would discourage you from yielding to the guide tube sensation. We're going to go through a sequence of treating a right-sided lower extremity problem. And these are the options this is the process to go. So you have a right-sided lower extremity problem. You start with the upper 1/5 contralateral sensory area. So you go to the left upper 1/5 sensory. If that doesn't give you what you want, you reinforce that left upper 1/5 sensory by going a little bit posterior, appealing to the idea that you might be just going along the anterior edge of the cortex, and you want to go a little bit posterior to make sure that you are over the cortex, and you're going a little bit inferior to the starting point to make sure that you've covered the territory adequately. So you reinforce it with the contralateral sensory area, a little bit inferior, a little bit posterior. Now, you can't tell because of the angle of this photograph, but the first needle that we put in, this is the midline marker, the top of the motor cortex, the top of the sensory cortex. Here's the fine needle that runs down to here. You see that? Now the entry point for the upper 1/5 sensory contralateral actually starts on the ipsilateral side, and it crosses over the central sulcus as it then threads along the sensory cortex. The follow-up one is farther inferior and farther posterior. Now, why am I emphasizing that? I'm emphasizing that because if you go back to the homunculus, you notice that the foot halfway up the calf, as well as the genitals, are located inside the sulcus. So you want to get as much of that territory as possible by starting ipsilateral, given that that's an approximation itself, and cutting across the sulcus, sliding into the upper 1/5. All right? Will that stay in? All right. We want to start, the main zone, because of the wiring, needs to be contralateral to the issue that you're treating. We want to make sure that we get as much of that sensory cortex as possible. Given that the sensory correspondences actually climb up the inside of the sulcus before bending and going down the outside of the cortex, we start on the ipsilateral side to make sure that we've captured as much of that in our influence as the needle can. Because as you see here, usually the images don't have it all the way up to the knee, but here you've got foot, ankle, knee, and genitals linked to this ascending interior border. The closer you can get to that with your needle, the stronger influence you will have on the entire lower extremity. So we make the first needle. We make the first needle just a bit on the ipsilateral side as we're threading it along the sensory cortex. All right? Get your patient to test it, to challenge it. You know, if it's a walking issue, get him to walk, or if it's a hit on and hurt issue, do something to make it hurt that gave you the original number. And see where you are. You do that after this point. So we've done this point, we tested. It didn't give us enough. We do this point, which is reinforcing the contralateral motor. Tested, we didn't get enough. It's unusual that you don't get enough with 2 needles. If you don't get enough, then reinforce it with the contralateral motor area. Right, so we're still on the contralateral side. We're still in the upper 1/5. Our first needle didn't give us enough. The second needle didn't give enough. So rather than putting more in the sensory, put it in the motor. Test them, walk them, have them show you. You want to get the pain down to well over half what it was when you started. Ideally, down to in the 2 to 1 range or below. If that doesn't give enough, well, sorry, this is just another shot of the same thing. Your first sensory, your second sensory, your reinforcement of the using the motor. And if you don't get the result you're looking for with that, you go to the ipsilateral sensory because of the crossover. Go to the ipsilateral sensory. Here we have the contralateral sensory number 1, contralateral sensory number 2, contralateral motor. If you need to reinforce yet another time, do an ipsilateral sensory, noticing this time as well, we've started just slightly on the contralateral side to get over to the ipsilateral. Slide that in there. By this time, you should be getting some convincing results. If you don't get the results that you want, then finish off the treatment and either go to the zone of the problem or go to ear to break through it. This is a reliable enough treatment that it should give you something if it's going to work. It's rare that you get nothing at all from scalp. Right? And you heard enough testimonials this morning from people who've moved farther forward with their training than you about how reliable this is. All right. Any questions so far? All right. Yes?
So if you do that first contralateral sensory needle and they get the results you want, you don't have to do any of those.
Correct. Correct. We're just giving you the options if. You got it.
You ever go to ipsilateral motor?
I would only go to ipsilateral sensory. I mean, unless there's a strong motor component to the problem, then you can go to ipsilateral motor. Yes, but at this point, you know, you're getting close to Hail Marys here. Fine, whatever your treatment is, whether it's this kind of a treatment or a bilateral treatment for central back pain or cervical pain, whatever the treatment is, you end your treatment with the foot motor sensory. Why is foot motor sensory called foot motor sensory? Because the foot is just inside the sulcus, and you're going from motor to sensory zones as you thread it. Foot motor sensory is 1 centimeter lateral to your midline marker, running parallel to the sagittal midline, also known as governor vessel or Dumo in traditional terminology. So you start at the midline marker, 1 centimeter lateral, 1 centimeter lateral, thread your needle as far as it can go. If you get less than half the length of the needle with your initial needling before you bump into bone, add another needle to make sure that you cover that entire area. Okay? So foot motor sensory always gets added as the finishing touch, as the period to a scalp treatment, whether you're working at the top of the head, the side of the head, the back of the head, or all of the above. Foot motor sensory. And this is what it looks like with sensory 1, sensory 2, motor 1, sensory 3, foot motor sensory marker. Foot motor sensory brings it all together, anchors it, fixes it. So don't not do foot motor sensory. Always with foot motor sensory, for any treatment, always at least 3 needles, exactly.
Do you ever just do foot motor sensory?
Do I ever do just foot motor sensory? Jason Howe recommends foot motor sensory for a long list of incurables, whether it's chronic fatigue or Lyme disease or traumatic brain injury or impotence, erectile dysfunction, but basically anything in the
Yes. Thank God I got a treatment. Every patient, right? Every day. Every patient.
you might call the placebo effect into play and say, this is, should you have? Of course you don't, but. Right. Yes, so the answer is always use it. So the answer is, would you do it alone? Rarely, if you're dealing with some kind of, if you're dealing with a psycho-emotional, psycho-spiritual challenge of post-traumatic stress, that kind of thing, then by all means you can use it. But in those cases, I would be doing other things as well. Okay? Now, what we're going to do is, let's at least at the beginning do this one by one, needle by needle. I'll have Alan needle me step by step by step so that you can see it, and then try to change your partners as much as possible. Believe it or not, working with a different head, working with more hair, less hair, gives you a versatility that you can't get by working with the same head all the time. Ollie at one point complained that all of these demonstrations are done on my head because it's convenient to see the stuff on my head. But you've got to get used to people with hair as well. So please change your partners, move to other tables. We've got plenty of preceptors to give you a hand. So just bear with us. We'll do one point at a time until you're comfortable enough that we can do additionals.